I think lung cancer is one of the more challenging cancers in all of oncology. When we think about patients with breast cancer or colon cancer, often there's surgery that's already occurred, and there's a lot of tissue for us to analyze and try to identify markers to help with care. In lung cancer, when a patient is diagnosed, often it's from a small sample that was obtained either through a scope into the lungs or maybe through a needle that was guided in using a CT scan. That material is so valuable. Not only are we trying to establish whether someone just has lung cancer or not, or they have a squamous lung cancer or not, we want to know more. And I think, and I believe everybody who does this on a full-time basis now believes that the opportunities for patients to benefit from oral therapy are so tremendous that requesting or pushing our patients to consider another biopsy to get more material is really a priority. And I find that almost every time when I talk to patients about this, they're willing to undergo that biopsy. Now, I think some of the exceptions might be patients that aren't sure they want to do therapy at all, or patients who've maybe had a horrible experience with their initial biopsy. I understand that, and I think still in those patients, sometimes deferring the conversation for later in their care is helpful, that maybe with time they can come back and consider that again. As eager and as exciting as I am to do that for patients, I do understand it's always a cost. I hope it can be as easy as an outpatient procedure and going in and going home the same day and we have results, but there's so many ifs along the way. We may not get the needle that we think is going into a spot may not actually hit that spot. Or the needle gets into the right place, but the material we get back is showing that there's cancer that's part of it's dead, or what we call necrotic, that's not usable for the pathologist to do these extra tests. I've had that happen before. We've all had these rare complications occur that even can be life-threatening. So I don't consider the request for a rebiopsy lightly. I know it's a big undertaking for patients and families, but I think the payoff, the potential reward is so large it's worth taking. I can think of an elderly patient I've taken care of where we actually had to do this 3 times, but we finally discovered that he had an ALK rearrangement, which offered him an opportunity to get an oral therapy, which I think would afford him a much better course than standard chemotherapy.